Hello, my name is CJ Witherow. I'm the Chief Operating Officer for our region, and I'm here to walk through with you what the Parity Program is and what changes that will mean for both our practices and our system and the electronic health record. So we'll be covering the what and why of parity. We'll be reviewing the training manual, the key elements of that manual that will be available in the help section of Cricut and Word form. We'll be reviewing the levels of care for the populations that parity needs to be applied, and we'll be looking at the Cricut system changes and how that will impact your workflow. With the what and why of parity, the parity rules started with a federal law called the Mental Health Parity and Addiction Equity Act of 2008. And I won't go into a lot of detail about it, but essentially the federal parity law states that health insurance groups and health insurers that provide mental health or substance use disorder services have to provide those benefits in ways that are not imposing or not less than or less favorable than the way that benefits for medical or surgical benefits are applied. With the federal parity rule, the state needed to address what's called non-quantitative treatment limitations. And all that really means is in the medical world, there's a lot of specifics around different diagnoses, different clinical needs or medical needs that have specific descriptions or parameters about how each of those conditions are treated. With mental health, we don't have that level of clarity and specificity. So what the parity program is requiring that in ways where we make service decisions about the amount, scope, or duration of benefits, or use utilization practices like prior authorization, we need to apply those ways, we need to apply those rules or those applications in ways that are comparable or less restrictive than how those would be applied in the medical world. The only part that you really need to know about that is the state did their own assessment of what that means, what services and what populations would need to be applied, and then what the next steps would be. So with the state application of parity, what the state decided was to create a parity work group that began in January of 2018. The state tried to address parity from a broader approach and was not able to determine from a statewide perspective how each PIHP would apply the parity program for mental health and substance use services. So they basically decided that each PIHP would come together, and where we could come up with statewide decisions, we would. Where we couldn't, that each PIHP would come up with their own parity program and report that to the state, and the state would oversee it. And maybe someday move toward a statewide program, but for now, that wasn't the goal. So what we'll be talking about is what that state parity work group worked on and what they developed in terms of what each PIHP needed to address. What we'll be covering in this training are the areas here that are highlighted. What we won't be covering are some of the programs and service decisions that the state has already created a parity program for. Those are the urgent and emergent mental health services. And with that, the state has already purchased and required PIHPs to apply the MCG and DSHA guidelines, which are in our electronic health record right now. We applied those a couple of years ago. They also made the statewide decision for substance use disorder services that all PIHPs would use the ASAM criteria and document that in the record. What the state could not come up with in terms of a parity program was how to apply that for adults with a mental illness, children with a serious emotional disturbance, and the persons with an IDD or CI diagnosis. What the state did develop and require is that there are certain functional assessments that would be used with each population to help with developing a parity program. So for the MI adult population, we are to use the locus, and if you work with that population, you've been trained in how to use the locus. With children with an SCD diagnosis, the CAFS, PECFS, or DECA was purchased by the state and is applied across those populations, and people who work with those children are trained in those functional assessments. And then with the IDDCI population, this state required the use of the SIS assessment as a guide. So those are the three populations we'll be talking about in how the parity program was developed for our region. In our region, we came up with a parity work group to look at how we would apply a parity program in our electronic health record and how we would train staff and roll out the system. And then in terms of creating the parity program for each population, a group of clinical and utilization management experts were brought together specific to those populations to come up with the parameters. So with developing this program, we looked at our own utilization for a historical review of our own utilization, how we've authorized services, how services have been used for each of those populations to come up with parameters to make consistent and fair treatment decisions and utilization management decisions in the way that the parity program and the parity rules require. So what we'll be talking about is in relationship to the parity training manual. And these slides follow how the training manual also flows in the table of contents. We'll be talking about the policy and practice and some of the standards or rules that were set up for the parity program. And we'll also be talking about some of the procedures and some general rules around how the parity program is being applied. Again, for these three populations, the locus with adults with a mental illness diagnosis, the CAFS, PECFS, DECA for children with an SCD diagnosis, and people with an IDD or CI diagnosis. So moving into some of the general standards around assessment and level of care determinations. With each functional assessment, there is a level of care or a score that gets applied to that person when the functional assessment is completed. The score itself is a little bit different depending on the type of functional assessment, but it's standard that that score is used to determine where that person falls on the level of care. So using that functional assessment for that applicable population and using the accurate level of care score or number is key to the foundation of the parity program. The functional assessment that gives us that level of care score must be completed before the biopsychosocial is completed or signed. That's to make sure that the electronic health record has the correct level of care score in the record. If you sign the biopsychosocial before you finish the functional assessment, you won't have the correct level of care score in the record, and it will affect what the system tracks and how the system sets out the rules in the backdrop of the authorization module when you go in to develop the plan and request authorizations. And that will be clearer as we go through the rest of the training, but it's important to know that the functional assessment has to be done before the BPS is signed, because that score really drives what the system does for that person's parameters in the electronic health record. This doesn't change the ongoing practice we've always had that all other assessments specific to somebody's needs or requests still needs to be completed before the plan of service, or determined and documented about when that's going to be completed in the plan of service. And for people who have an IDD-CI diagnosis, as we know, the SIS assessment isn't required right now. People can opt out of that, and it's only done every 3 years. So if somebody has a SIS assessment, you would use the current score to develop their level of care. If they've opted out of a SIS assessment or haven't had one yet, there's descriptives in the parameters and the guidelines around what their functional level would be and what their score would look like that you could still use. The level of care determination is documented in the IPOS section of the electronic health record. We'll show you what that looks like when we get to the cricket section of this training. And any level of care changes outside of the annual IPOS process will be updated in the record through a new functional assessment and or updated as a new level of care in an IPOS amendment. So what that means and what's important to note about that is there's a difference between a rollout of this new parity program and levels of care, and then the standard process once that upload, that initial rollout is completed and everybody's level of care is in the system, and then we move back into standard operations. So once the system rolls out the changes, there will be a period of time where staff will be able to update the level of care in the system in a much easier, streamlined way using the current functional assessment and entering the level of care score directly in the record. Once that streamlining process is done and we have the upload completed and the rollout completed, any change in somebody's level of care is going to happen in the person-centered plan meeting in the IPOS process. If that level of care score needs to change midstream in the middle of an active plan of service, that plan of service and that level of care would need to be updated and done through the IPOS amendment. And as usual, level of care determinations, any special review matters that might have to happen with a service request, and we'll talk about what that means in a little bit, need to be discussed with the consumer or guardian as part of the person-centered planning process. And if there are any adverse determinations made, any kind of denial, people still have the right to file a grievance or an appeal and get the proper notice for that. That's just to say none of those processes change around person-centered planning and appeal rights. So some general rules about what level of care means. The level of care number a person falls under is, again, as I said before, determined by the score of their functional assessment. The level of care document for that population will describe which scores apply to which level of care. So each population has a guideline, a spreadsheet that explains the parameters for that population based on level of care. And I'll show you those in just a little bit. All service parameters or populations progress from a lower to a higher level of care number. So a lower level of care number is always going to be somebody who's at a higher functioning level and will have a lower need in the amount of type of service in order to achieve their goals. A higher level of care will always mean that somebody presents with maybe lower functioning levels and a higher need in the amount, type, or array of services in order to achieve their goals. And those rules will apply to every population. So the higher somebody's number goes in their level of care, the higher somebody's score is, the more functional needs they're going to have, and the greater need they are going to have for services in the array of services. There's a couple factors that the parity program has allowed that are different than our current practices in how we request services and authorize services. With the parity program and with the analysis that's been done, there are now some services that once you enter them in the authorization, they will be automatically approved. And that's based on the analysis and how we apply the parity program and what's allowable with how the state set up that system. So there are going to be services that do not need or supervisor approval. As you know now, if you enter an authorization, every authorization that we do has to go to somebody else, either a supervisor or staff, and be approved by that person. With this new shift in parity in the parity program, there are some services that once you enter them in the authorization, the system would automatically approve them. And there's no need for sign off by anybody else. These include essentially services that are available for everybody, that everybody might need them, regardless of what their level of care is, or within that level of care. And those include things like certain types of assessments, functional assessments, plans of service, periodic reviews, drop-in centers, and engagement centers. There's not any kind of preset maximum or limit to these services. They can be used as much and as often as they're needed for what the individual presents with their own needs. What it doesn't change is the need to make sure that the plan of service has those services in the plan itself and how those are relevant to their goals. So if it's going to be in the authorization, same as it's been in how we write a plan of service, how we've always written plans of services, if it's in the authorization, then that service needs to be in the plan of service as well. There's also a shift with particular services with the psychiatric treatment team. And those include psychiatric evaluations, medication management, injections, and nursing services. Because the federal definition of medical necessity includes that if a doctor or prescriber is providing and requesting these services, they are predetermined to be medically necessary. So again, a review of the parity program and some of the federal rules around that allowed for some shifts in how we authorize services and whether they need to be pre-approved by a supervisor or staff or not. So with these types of services, they can now be added and updated to the plan of service when the doctor or prescriber recommends or requests them. And the authorization for those services will be auto-approved without needing to be approved by supervisor or staff. There is also no preset limit or maximum on these services, and it doesn't require any kind of special review. Essentially, if the prescriber is saying that somebody needs those services, they are already predetermined as medically necessary. What this doesn't change, though, and what's important to note, is the prescriber is still required to document in the record of the need to continue services and when and how often the person should be seen. So the prescribers might be familiar with that in terms of psychiatric evaluations or medication management. They would also need to address that with injections and nursing services to include that and those communications with the treatment team and the case manager about what that person needs. So it's still important to have that in the record. And of course, the plan of service, as always, still needs to include these services in terms of how they're related to the person's goals and the amount, scope, of duration. So this will require close communication with the psychiatric team and the team that's managing the plan to make sure what the psychiatric treatment team has determined that person really needs is updated and current. And then there continue to be, as there have been for all the services up until now that we enter an authorization in, services requiring supervisory approval. These are services within a level of care, even within the max limits, that still need to be requested for a secondary review. And these also include potentially some types of assessments that need to be completed before the staff reviewing that authorization request can approve or deny those services. And those are some of, again, the standard practices we've had with services such as CLS, overnight health and safety, respite, home-based, and other services like ABA that need a previous assessment to determine A, if somebody needs them, and B, the amount and scope of how much they need. So this is really no change in practice for us in terms of how we've done authorizations up to this point. There are rules around service maximums with these levels of care, and it's important to talk about how that affects the individual plan of service. So with these levels of care and the guidelines that are within them, which you'll see a little bit later in this training, The electronic health record will have already set in the backdrop of the system what those rules are. So if in, let's say, a level of care 3, there's a maximum amount of what somebody would be needing or what the benefit would look like for that person with how many CLS hours a week they would get or how many CLS hours a month they would be in need of. If there's a maximum to that, the system has that rule already in the backdrop. And how the system keeps that structure and sets those boundaries is based on the plan of service start and stop times. What it doesn't impair us from, however, is once a plan of service starts and then ends, the count for that maximum starts all over again. So for example, if you have a plan of service that lasts for the entire year and the person's benefit maximum, say for CLS, has been set and they stay within that benefit maximum and what they've needed has been within the guidelines, the plan of service goes along as usual, and there's no outlier, no exception that has to happen. If within that year something changes in that person's need, let's say they have a higher need for CLS, maybe they've even had a higher level of care score and that moves them into a higher benefit plan. If you were to end date that plan of service and end date those authorizations, the maximum set for that service, even if it's in the same level of care, the maximum set for that service will restart. So let's say I have to end somebody's plan June 1st. I start a new plan from June to the end of the year in December. The system will reset what those maximum amounts are for that level of care. That essentially kind of protects the system from running out of the benefit plan or the eligible services for that person prematurely. As I said before, some services will need to be pre-approved by a supervisor or staff because that service requires a special assessments and the amounts are highly person-centered. There's no utilization data that clearly defines that parity program. So for example, supported employment is a service where there's not consistency around utilization. It varies enough where it would be person-centered based on that person's assessment. So this kind of reiterates what I talked about before, that if you start a new plan and within the year, the maximum is reset for that plan. If there are service maximums within an IPOS year, there are times when maybe there are authorizations that change within a plan of service, or there's a use of interim plans. It's important to note that this parity program doesn't speak to interim plans. It only speaks to a plan of service that's assumed to be an annual plan of service. So in the case of interim plans, your CMH or you supervisor may have limits on how often or how many interim plans can be created and what type of oversight will occur in the use of interim plans to prevent the overuse of those types of plans with the IPOS process and the parity program. So this program doesn't speak to that. Your CMH will give you their own guidance about how they're going to interpret or use interim plans in this system. If a consumer ends up needing more services than that level of care maximum allows, and you might know that by looking at the guidelines, you might know that because you'll get an error in the system, and we'll talk a little bit about what those errors look like and what they mean. What will happen is you'll discuss the following options with your supervisor staff. You either might need to look at completing another functional assessment, and that person might be actually at a higher level of care than what we originally thought they were. And if there's no justification for a higher level of care, there's still a way to request those services, and that's through what's called an exception process. And the importance of that is as we're entering these authorizations and using this parity program, there's a lot of data that's going to be collected in how the parameters are working, if the parameters need to be changed or revised. And part of that includes if we have a high rate of exceptions, that basically means that maybe the parameters we set for that level of care need to be adjusted. So part of what we'll be doing with this parity program is looking at the data, looking at what's happening with the parity program to see, are the parameters that we set accurate? Are they working? Do we need to change them? And one of the red flags for that, or the triggers for that, is if there's a high rate of an exception review needed for a certain service or a certain level of care. That's usually an indicator to take another look at the guidelines. And then we would actually go back, we look at those and change those in the system, so there wouldn't have to be those exceptions down the road. So there's still a possibility to ask for an exception, and it's important that we track that, because because this is a new system, this is a new program. We used our own data to make those determinations and use the clinical expertise to figure out what those guidelines would look like and what the parameters look like. But being a new program, there certainly are going to be lessons learned, and it'll be a process where we'll be continuing to improve and take a look at if adjustments need to be made to the program. So services that would require a special review or an exception review, like I said before, some services, that person that you're looking at might need more services than what their level of care guidelines have structured, and you would need to request an exception. Some services, just by definition of the service and the requirements around what the state has created with those services, will always require a special review. And really, we already do special reviews for these types of services. Just how it will change in the system at this point is if you attempt to enter an authorization for these services, the system will not allow you to go further and require the special review and the secondary sign off. So examples of this, which again have been standard practice for us, are things like electroconvulsive therapy, specialized licensed residential, and state institutions. With state institutions, as you know, there's not necessarily going to be an authorization for that. But if it is being recommended, there's already a process in place that needs to be done. So really the practice of this doesn't change. It might change whether you can enter an authorization in the system at all. And with some services like state institutions, though, even putting an authorization in the system wouldn't apply. But the exception review itself would be a part of the necessary structure of reviewing those services. So when it comes to COFRs and the parity program, we made a decision that in cases where somebody is being served in another county and your CMH is funding and managing those services through a COFR, that there isn't going to be any kind of automated pre-approved services like there are in the parity program for people who are being served within the CMH that I discussed before. Because of the monitoring and the process with COFRs, it's important that any service that's being covered by a COFR be reviewed by your supervisor or staff as part of monitoring the COFR. So the system may have a way of tracking that if somebody's set up in a COFR, and it's just important to know that with a COFR, regardless of the type of services, regardless of the array of services, regardless of the level of care, there's always going to need to be a secondary review of that COFR. So we're going to talk a little bit next about the review of regional parity parameters, the parity parameters that we came up with as a region that were the populations that the state assigned each PIHP to develop their own program with. So the level of care creation process itself, I talked a little bit about that before. We had a regional parity work group that looked at what needed to be created in our system, what the rollout would look like, what training would need to happen, and then some of the clinical and experts to take a look at the data about practices, previous practices, and what our guidelines, what to propose for what our guidelines would look like. We also have a plan, as I said before, to review the data with how parity is working and if there needs to be any changes in the system with what those parameters are, if they need to be updated or revised, and if there need to be broader approaches or changes in the authorization system and the behind the scenes rules. With the locus levels of care and the CAFIS, PECFIS, and DECA levels of care, the state essentially said that each PIHP had to have a parity program that addressed these two populations. While they require the CIS assessment to be done for the IDDCI population, they had a different approach with what parity was supposed to look like for this population, and I'll talk about what that means in a little bit. So the first level of care parameters we're going to look at are the MI adult parameters, and I'm going to share the spreadsheet. This spreadsheet will be available, it is already available in each of the CMHs. And at the end of this training, you'll have the list of the local CMH staff who worked on these parameters or worked in the regional parity work group. And this gives you an idea about what a level of care means for each number in this population, what the services are within that level of care, what will automatically be approved, and what needs pre-approval. It's not necessary to memorize this. It's nice to have these guidelines as a reference. They are going to be available in each CMH system for reference. But as long as you know the level of care number, and in this case, it's the locus score, and that correct locus score is in the system behind the scenes will already have the rules in place for what that level of care is. So as I said before, all levels of care go from lower to higher, with lower being a higher level of functioning, less of a need for services, and a higher level of care number being a higher need and a more intense need for the type or array of services. So for level 1, with the MI adult population, again, it's got the services that are available without any kind of approval that I talked about before. And really, this level of care is for what's called recovery maintenance with the locus, if you're familiar with the locus. Either an individual who really is in maybe a meds only clinic or needs short-term care to stabilize, or maybe transitioning out of the CMH system and just needs some support as they're transitioning. And again, as you go higher with the level of care, you're moving to a low intensity community-based locus score. You're going to see more maximum amounts of services within this. And possibly some additional services. Then with a level of care 3, which starts with the high intensity community-based services, you're going to see more services available with more maximums. And the important part of some of these levels of care is there is a point with a level where that sets where a more intensive type of service might start. So with locus for a level of care 3, you're going to see the onset of ACT services is either a transition or step down services, as well as a wider array of services. So at minimum, a level of care 3 would make somebody eligible to transition, possibly transition into or out of ACT services. Maybe they've had success in ACT and they're ready to step down from that. Maybe they're transitioning into ACT and it might not be clear what the intensity is for them at that point, or maybe it's just a short-term need for ACT sometimes, and they might not have the necessity for the intensity that a full ACT program implies. And again, as I said before, you're going to see more services. That's where CLS comes in into availability with the benefit package, where supported employment has a higher need or a higher availability of services. And then level of care 4, again, with the locus, that's a locus description of the medically monitored non-residential services. That's where somebody who has a need for ACT, for full ACT, begins, and or intensive case management, and the amounts of service available in that benefit package will increase. And then, as we talked about before, there's exception reviews that are inherent in some of the services. There has to be a special review for somebody who's going to be admitted to a specialized residential group home, to partial hospitalization and or ECT. And really, in terms of those services, that's why they're in level of care 4, where level of care 4 would imply that there's a higher need for that service. So that's why those services are entered into the level of 4 area, where they become evident, where they begin. Level of 5, level of care 5 is medically monitored residential services. Again, that's a locus definition. And again, you're going to see a higher amount of services, and that's where specialized residential, crisis residential, there might be a more intense need for services at that point. And then level of care 6 is the highest level with the locus. And essentially you're talking about with the highest level of care, with most of the levels of care with the population, with the highest one implies there's a need that probably is going to require that person to be out of their community temporarily. Usually implies some kind of hospitalization or long-term placement. The level of care with children with an SED diagnosis, same rules. Low level is mild. Highest level is an out-of-home or out-of-community placement. And the layout of the children's SED program looks a little bit different. Each group did a little bit different structure with how they set up their parameters. So obviously the clinical experts around who serve children with an SED diagnosis created these parameters. And again, a low level, a mild level may have a very low need or a minimal amount of services. And the higher level you go, the more services become available to that individual, or the more amount and scope of services become available in the benefit package. With the SED children's level of care parameters, the onset of services like home-based, wraparound, CLS would begin at a level of care 2, but more at lower maximums. Similar to ACT, they might need to have a short-term intervention, or maybe something like a step down or transition. experience with those services, and then the level of care 3 into 4, the intense, is when there would be higher maximums to the benefits for those services because there would be a higher need for more of those services. And again, the highest level with children with an SED diagnosis would be some type of out-of-home placement, which would require an exception review or a special review. Now we move into the individuals with an IDD-CI diagnosis. Just a note about this particular population and the level of care and the authorization changes. While the state required the use of the SIS assessment for this population, they have not required a specific parameter program for the population. The reason that we needed to come up with some level of care parameters is all of these level of care parameters are programmed into the authorization rules in their electronic health record. And basically how that system works is if you change the authorization rules for one population, you have to change them, you have to change those rules for all populations. It can't pick and choose from children to adults with an IDD-CI diagnosis that some could have authorization rules and some couldn't. Therefore, we came up with a level of care parameters for the system to be able to read and use in the backdrop of the authorization module. But we did it in a very different way, again, because there's not state requirements about making a very specific parity program for this population. So as you'll see, we have level of care connected to services, but not amounts or scope, and I'll show you that in just a second. There will still be services that don't require prior approval, the same types of services as with the other level of care populations that we described earlier. And with all services, there's no maximum or minimum with the amounts. They only are delineated in the level of care in terms of the types of services that person might be eligible for in the benefit package. And that, excuse me, and that delineation really depends on services that might be available to them in a more intense level, like the habilitation services waiver. So what we basically did is came up with a level of care criteria for this population that was based on the SIS assessment score. And that SIS assessment score, the SIS assessor who completes that does send you the score. It's available in the record, so you'll be able to access it. And again, if they haven't had a SIS assessment yet, there are some descriptors about what that person would possibly present with and where they would fall in the level of care. When you look at this level of care, again, it's quite different. It only has services, not amounts, not minimums, not maximums. And essentially, it really has every service open to it, with the exception of the services that fall under the HAB waiver. If someone is eligible, whether they're on the HAB waiver or not, it doesn't necessarily mean that they have to be on the HAB waiver. But if their level of functioning puts them at a level of care of 4 or higher, which by definition would make them eligible for that HAB supports waiver. Again, whether they use it or not is irrelevant. It's just in terms of their intensity of need. Then if they're on the HAB waiver, they would have services eligible to them that other individuals wouldn't. And that's really the only delineation. So the system in the background is going to have all these services available. There's not going to be maximums or minimums. There will still be services that need to be reviewed by the UM or the supervisory staff around what you're requesting. If they don't have those pre-approval, no approval rules required, like for the other populations. We will be taking a look at the data around this to see if there's any way we can make this even more efficient for the authorization module, but really it's pretty wide open. The only delineation, like I said, is there may be some services within the C waiver that people are eligible for. So I would say with this population, with entering an authorization, you're probably going to see the least amount of changes with the authorization system and how we currently practice with the IDDCI population. There really wouldn't be, by definition of what the state is requiring, a lot of stops with this program itself. It's just the authorization module, and Cricket has to have some kind of rule to apply. So now we're going to move into the system changes in Cricket and what that looks like in Cricket, or what that will look like. So where to see somebody's level of care is going to be in some key places in the system. First is the dashboard will have what that person's current level of care is. And this is in the Cricket training mode. This will be live in the training mode, I believe, up until May 13th, if you want to take a look at it. But the dashboard will always have that person's level of care. This person is in the population of adults with a mental illness, so they have a locus level of care score up there. Also, in the consumer information section, their current level of care will also be available and be able to be seen. It's key to know about the consumer information section, because as I said before, with the rollout and trying to create an efficient way to upload everybody's level of care score without having to update the plan of service, go into the plan of service, with the initial rollout and implementation, we've streamlined a way to simply enter that person's level of care in the record so that it'll connect to the system, and the rules behind the authorization system can start for that person based on what their score is. So when you get the notice that the system has implemented this change, that Cricket has gone live with this, you'll have the ability to update their level of care score right in the consumer information section without having to do all the plan of service processes that we'll be doing once the rollout is complete and everybody has a level of care score. So by that, what I mean is you'll go into the consumer information, sorry, and click on the change option. And when you go down to the bottom of that page, most likely there's a possibility that there might be a level of care score already in there for that person, but it might not. More likely, you might have this be blank. And then depending on the person's population, what their diagnosis is, you're going to choose from the applicable level of care score based on the functional assessment related to their diagnosis and what functional assessment was done. So for this person, because he served in my adult department, he would have a level of care locus score. And I think he had a previous score of 4, so let's continue his level of care score. But this is where you'll be able to first enter the level of care score when the rollout occurs in the system to make sure that that person has an active LOC number in the system. There will be a time period that's determined by the regional EOC committee about how long we will have to use this streamlined approach to get the current level of care score into the record. So this is an interim option. This is will be available in the initial rollout. And then again, as I said before, once the rollout is done, and that period of time is determined when the cutoff would be to get the scores in, the update would happen through the plan of service. And this is what that would look like with the plan of service. Once the initial rollout is completed, if somebody's level of care score changes, they need to go to a higher level of care or a lower level of care. How you would do that would be in the IPOS meeting section. Through the change system, and then right here with our benefit plan, you would be able to update it through that section. So as I said before, this would be the way after the rollout, after the initial implementation, once everybody's score is entered, moving forward, the standard way to update a score after that will be through the IPOS meeting. And that's the only way it can be updated after the initial rollout. And then you'll also see in the authorization itself, once you're in the authorization part of the record and entering authorizations, it will also remind you of what that person's level of care is at the moment. So you'll have that parameter and that idea about what the system has identified, which means what rules it's set up around the authorization module. So with that, with those rules that the system is tracking, there's some errors that will come up that are helpful to understand what they mean. And these may come up, they may not, but it's just important to know what these errors mean. The first error that might come up is that the consumer does not have a level of care set. So this will get triggered when there's not a level of care in the system for that person at all, and you're trying to enter the authorization. So the fix for that is making sure the current level of care is added in the record. And again, if we're in the rollout implementation, you'll be able to go right into the consumer information section and update that through here. But if we're post implementation and we're back in the standard process, you'll need to do that through the plan of service. The other error that might come up is the service is not in the consumer's current level of care. So this is triggered when the service you're requesting doesn't exist in their benefit plan based on what their level of care is. So you have basically two options: to review whether that level of care is accurate for that person or needs to be updated. If it is the accurate level of care score and they fall within those parameters of what the score is saying, then you would still be able to request a special review through your supervisor for that service or for the amount of service. But I think in this error in particular, the error is going to be the service itself that you're requesting is not in the consumer's current LOC. So let's say you've got somebody at level of care 2 and you're asking for community living supports, which might not be in that level of care 2 at all, you would get that error. Another error you might get is the level of care allows number of units per IPOS, and you've met the total number of those units have been requested. Basically, what the saying is the allowed number of units per IPOS that this level of care allows for doesn't match the total number of units that have been requested. And this gets triggered when the service and the units on the current authorization, plus any previously authorized units under that same plan of service, have exceeded what the maximum is. So this is what I talked about before, is if a plan of service start date and end date goes through the full year and you've exceeded the amount that's allowable within that benefit plan for that level of care, and you're asking for more services within that same plan, you will get this error. Sometimes that means there's an authorization that may needed to have been um, updated. If there's a previous authorization that was early terminated, those units will still count towards the maximum amounts. And this only occurs if it's the same plan and you've gone over the maximums. Like I said before, if you have a plan of service that ends mid-year and you start a new plan of service, the count starts all over again. The count gets reset. This is an ongoing plan of service that's for the whole year, and you've exceeded the maximum amount that that benefit has set up in the system. The fix is basically either a special review that you would discuss with your supervisor or UM staff, or there may be issues with the plan of service authorizations that you might need to go in and fix depending on how previous authorizations have been set up. The last error that you might get is the level of care allows a certain number of units per authorization, and you've requested a different number of units. This is triggered when the service that's listed in the benefit plan, there's a service in the benefit plan, but the amount that you've asked for exceeds the maximum. So let's say somebody's in a level of care 3 and the maximum amount of CLS is 8 hours a day, and you've requested 12 hours a day. It's beyond what that benefit plan has as a maximum. So one of two things could be a part of that fix: either review whether that level of care is accurate, or maybe that person falls into a higher level of care, or request a special review. What we've done with creating the maximums with these benefit plans, it's important to note, is when we did the analysis and we came up with the maximums we set were even higher than what kind of the norm was for the amounts of service. So we tried to create a system where we hopefully won't run into a lot of situations where the maximum has been exceeded for what you're requesting. But again, this is an example of, we'll be looking at the data, and if this happens frequently with maybe a type of service or a type of level of care and services within that level of care, we would take a look at that and say, clearly there may need to be a shift in how we apply that benefit plan, and we may look at changing that. But the system will track when this is happening. And again, there are those two fixes to try, and you would be able to still have options to move forward with requesting those services. So that is essentially the overview of what's happening with parity and what that looks like in the Cricket system. The training system, the Cricket training module or training site has this in the system right now if you're interested in going and checking it out. We do have a go live date, an implementation go live date of May 16th. We wanted to give folks a little bit of time to review the training materials, to review this video if you want to. So the Cricket training system itself, the system will stop having this level of care option to check out in the training system by May 13th. We're going to close that out, and the system will go live on 5/16. So your local CMH will have some processes, and we'll discuss with you kind of what the plan is once the go live date of May 16th is in place, for again how to make sure that all consumers in those populations have an active level of care updated in their record. And again, it's that streamlined way of entering it in the consumer information for this go live implementation process. And then if you have any questions or you're interested in connecting, excuse me, with your local staff who is part of this parity work group, these are the names of the staff who are involved in this project connected to your CMH. So that brings us to the end of the parity program. Thank you for your time. And certainly if you have any questions, you can always reach out to me or reach out to your local staff at the CMH. And thank you and have a good day.